My talk here is about to unravel the complexity of the back pain and why some patients are improving miraculously in 2 or 3 sessions of treatment, whereas some patients, despite having a best possible treatment, not improving at all, even with time, even with medications, even with physiotherapy, or even sometimes after the surgery. It's because the back pain is not a single entity. The back pain is the culmination of so many other variables, and that makes the back pain treatment so difficult. Back pain is a symptom. We all know that back pain is not a diagnosis. Oftentimes I am seeing many posts in Instagram and other social media. Some of the physios as well as some fitness influencers and yoga masters, they are advised to do certain exercises for patients who have got discogenic back pain or sciaticas without even assessing their patients, and they say that do these 3 exercises for back pain, your back pain will be alright. And some yoga masters who self-proclaim as a back doctor is advising to do certain yoga stretches to cure sciaticas, and some fitness influencers talking about core strengthening exercise to cure the back pain. They all have only superficial knowledge about the back pain, and every back pain must be diagnosed. When we talk about the diagnostic guidelines, majority of the back pain, as per the available evidences and our clinical experience, the majority of the back pain are discogenic in nature or anterior column pain. When I talk about the anterior column pain, it constitutes the vertebral body and the intervertebral disc interposed between the vertebral body and the nerves and blood vessels that are governing the vertebral body, the intervertebral disc, and the traversing root and exiting root. So these are all the structures that are going to potentially cause the pain. So the structure which is causing the pain is called as source of pain, and the reason why these structures producing pain is known as cause of pain. For every back pain, there is a source of pain and a cause of pain. When you identify the source of pain and the cause of pain, then you can say that you have diagnosed the condition. Almost 70 to 80% of all surgeries that are happening in the world for the patients who are having back pain, the surgery is done for the disc. The disc is herniating, the disc is extruding, disc is sometimes undergoing sequestration and it causes canal stenosis, or it could be a instability due to anterolisthesis of the vertebral body. And these conditions are unanimously accepted as the classic diagnostic conditions that causes low back pain. Of all, the discogenic low back pain are the number 1 reason for the pain in the world, and the pain out of the disc can behave in a varied way, and this discogenic pain can come under the mechanical criteria or immunoinflammatory criteria. What do you mean by mechanical pain? Any postures or movements that influences the pain is called as mechanical pain. The disc being a loaded structure, being a compressed structure, it can respond to the mechanical activities, like when you sit for a long time, when you bend for a long time, when you lift weights, when you jog, when you run, the disc can undergo mechanical deformation, and that can influence its own pain. Especially during the disc pathology, let's say when the disc is herniating, it can go and choke the nerves in the spinal canal. Either it can compress the traversing nerve or it can compress the exiting nerve, depends upon where the herniation is. This mechanical migration of the position of the disc is going to compromise the structures around the spinal canal, and how much the herniated disc is going to compress the nerve can be graded from the scale of 0 to 100%. Sometimes the bulge will be so less, the compression of the nerve will be so less that the patients will hardly have any symptoms or very mild symptoms. Sometimes the herniation will be so severe that it just chokes the nerve, almost like the nerve cannot breathe, the nerve cannot get the blood supply. That is mechanically compromising the nerve. Do understand, when the disc is herniating, it migrates and go and mechanically chokes the nerve, which produces the mechanical pain. These are the people who tend to respond with physical therapy, exercise strategies, some forms of unloading exercise, some form of corrective exercise, sometimes a back brace. Anything which you do to mechanically alter the position of the disc, that could respond to people who are having mechanical pain. But the problem is not as simple as that. Some people may have only mechanical pain. Many people will have a combination of both mechanical and inflammatory pain. And such inflammatory pain are indeed a neuroimmunoinflammatory response pain. That means whenever the disc is bulging or herniating, the disc being a pro-inflammatory substance, the disc itself can release the inflammatory mediators, or we call it as inflammatory chemicals like IL-3, IL-6, TNF alpha, substance P. So these are the chemicals which will be poured in and around the nerves to make the nerve pick it as a chemical messages. We have mechanoreceptors to pick up the mechanical pain. We have chemoreceptors to pick up the chemical pain. So the structures in the back will have both these receptors. So some structures will pick up the chemical pain. Based on how much chemicals are released, the chemoreceptors will get activated, and then that informs the brain about the chemical pain. This immunoinflammatory mediated response for any type of tissue trauma is inherently decided. That means every body type is different. So some discs will cause so much of inflammation around it, whereas some discs will have less inflammation. That's why some people who have more of inflammatory pain, they don't respond to any physical therapy exercise. Movements and postures will rather worsen them. Even during rest, they will have pain. That is the characteristics of chemical pain. These are the people who need even medications, sometimes anti-inflammatory tablets, sometimes steroid injection. We call that as epidural blocks. So it depends upon what type of pain they have. Some would have predominant mechanical driven pain. Some would have predominant inflammatory induced pain, and some would have 50% of this, 50% of this, and we have so many permutations and combinations in that. So it needs around 1 or 2 sessions to get to know what type the patients fall in. Accordingly, you can decide what treatment is appropriate and assure the patients about the timeline of the treatment, when the recovery can be expected. So you can do some reasonable prediction based on getting to know what pattern they form under. For example, when someone has 80% of mechanical pain and 10% of inflammatory pain, but sometimes when the inflammation is so much, then it takes around a month or so to get the pain relieved. Sometimes some of my patients, they took around 2 months to improve, 3 months to improve. Sometimes some of my patients, they took only 2 days to improve. It depends upon what type of pain they are having. It's our job to diagnose and decide what category they fall in. Accordingly, you can give at what point of time they may expect the recovery. To add more confusion, we have one more variable, which is called as neuroplastic cognitive variable. You know that people, they get used to the pain. They train their body to get used to the pain. Few days back, I got one patient who was having chronic low back pain, and I asked him, how long you have been having pain? He said he was having it for the past 10 years. I asked him, why you didn't meet the doctor? He replied that I don't want to meet a doctor because I don't want to get into all that MRIs and surgeries. I thought I will manage the pain by myself, and I have learned to manage with the pain, he said. It is not correct to learn to manage the pain. It's always important to diagnose the pain and see what to do to reduce the pain by doing a right diagnosis. But most of the patients, especially females in India, they get used to the pain. They think being a female gender, if they deliver a baby, if they get an epidural injection, it is normal to have pain, and then they learn to live with their pain. They tune their body to tolerate the pain, and they become master in managing their pain and still leading their normal day-to-day activities, only to get to know at certain point of time, maybe after 5 years, maybe after 10 years. I have seen people who are suffering 20 years of back pain. I have seen people who have got 15 years of back pain, and this back pain at some point of time can get worsen, and when the pain is unbearable, that's when they go to the doctor, and the doctor will give medicines. So what I mean to say here is that the nervous system will adapt. That's called as plasticity. The chronic back pain sufferers will get their nervous system adapted for the pain. We call it as a neuroadaptive changes. These are the people who proudly say that I am so good in tolerating pain. I never go to a doctor for any pain. I manage myself, and I don't know what the painless body is because I'm always in pain. It's a part of my life. And this neurocognitive plastic changes is also having a spectrum. Some people are extremely good in bearing the pain for many years, and some people, they will not take even small amount of pain. They rush to the doctor even for the slightest of the pain, which is also not so correct, because you don't have to go to a doctor for any small bit of pain. But if the pain is not going away in couple of weeks, and if the pain is recurrent in nature, that's when you need to seek medical intervention. When you see a patient with chronic low back pain, they'll be having a mix and match, or the combination of these 3 variables: mechanical, inflammatory, and neurocognitive. And every patient will fall differently in this spectrum. Some would have 80% mechanical, 20% inflammatory, and 30% neurocognitive. Some will have 20% mechanical, 80% inflammatory. So people who are having 80% inflammatory are the one who really suffer, because they will not be at peace due to constant pain. People who are having predominant mechanical pain and predominant neurocognitive factors, like if they have both mechanical 80% and neurocognitive 80% and inflammatory 20%, these people are champions in managing their pain, because they would have learnt what are the movements and postures that would worsen them. They wisely kind of avoid or manage, thereby they live with their pain. These three factors with its own spectrum, permutations and combinations in that, unless you do an in-depth analysis of their mechanical factors, inflammatory factors and the neurocognitive factors, you will not be able to get to know which body type they fall under. If somebody's back pain is influenced only by these three factors, fair enough, we could have still managed, but we have lot many other confusions here to add more varieties in the back pain patients. We have other many factors which add further complexity and confusion in this scenario. To start with, the level of disc herniation. Some people would be having L4, L5 and some people will have L5, S1. Depends upon which level of the disc is bulging. Accordingly, certain nerves are more vulnerable. For example, L4, L5 disc bulge would have more risk of having the L5 root compression, whereas in L5, S1, they have the risk of having their S1 nerve getting compressed unless until the disc bulge is foraminal or forlateral. Almost 90% of the disc bulges in the lumbar spine happen at L4, L5 and L5, S1. Nonetheless, we have seen the disc bulges happening in the higher level also. We have seen L3, L4 disc bulge, we have seen L2, L3, we have seen even L1, L2 level. The more higher the level goes, the more confusing the symptoms would be. These are the people will be having more of a hip pain, groin pain, abdominal pain and their flank pain, because the nerves which are compressed at the higher disc bulge will be mostly governing the hip, abdomen and the groin area, and these people will be thinking that they have real hip problem or groin problem, wherein these people will be really having a problem at higher lumbar spine like L2, L3 disc bulge. Is that all? No. Some people will have two-level disc bulges. They'll have both L4, L5 and L5, S1. And some people will have multiple level disc bulges. They'll have 3-level disc bulges. We have seen 4-level disc bulges as well. And people who are very old, chronic arthritic patients at their 70s and 80s, they'll have multi-level disc desiccation as well as canal stenosis. Such people will have kind of problem at all the levels. So we have seen that category also. Mostly young people will have 1 level or 2 level, but as age progresses, the level tend to get increased. These are all the varieties we see in terms of the levels of disc bulge. Following that, we have a severity of disc bulge. What do you mean by severity? How much the disc is herniating and how much compromise it is making at the spinal canal or at the foramen. Some disc bulges are mild in category, which does not really compress the nerves, especially when there is a central disc bulge. Since the spinal canal is having large room for the nerves to float around, even with a small central disc bulge, the nerves will slide away so that it don't get compressed. But if the disc bulge is more like moderate or severe, then it definitely can cause more compromise to the nerves. So we grade the severity of the disc bulge from mild to moderate to severe, and there's a special category here called as mass effect. Mass effect means the extruded mass will become so big in the spinal canal that causes severe compromise of the canal space. Thereby, the patients definitely need immediate surgery. If not, it can cause irreversible damage to the nerves. If it is a surgical emergency, the patient should undergo the surgery as early as possible so that he can avoid irreversible damage to the nerves. That's why all the physios who are treating low back pain patients, they should know how to pick up the red flags. They need to check for DTR, they need to check for Babinski sign, they need to check for saddle anesthesia and checking the muscle power of the great toe as well as for dorsiflexors, so that they can pick up the subtle signs of CADA equinhalation so that they can immediately refer for surgical opinion. Next variable is the type of disc herniation. This is based on in which locality the disc is bulging. Is the disc is bulging central, or if the disc is bulging paracentral or subarticular or foraminal or forlateral. So it depends upon which area the disc is bulging, accordingly the nerve will get affected. Central and paracentral disc bulges will affect the traversing route, whereas foraminal and forlateral can affect the exiting route. Accordingly the symptoms do vary. And what is the level of bulge, what is the severity of the bulge, and what is the type of bulge, all will decide what type of symptoms the patient will have. That's why every back pain patients are different. Some of my patients, they send me an Instagram message or by WhatsApp message and they send their MRI and ask me to tell them the best exercise for them. I don't have that best exercise in my hands because the treatment should be decided upon addressing all the variables that can happen only in the physical presence. And if someone says that I will give you some online treatment, I will give you 3-4 exercises for your back pain, and if they promise you to cure that disc herniation by online consultation, I think it's not so easy. I have tried few, but it's so difficult for me to do that, because I need to check the patients physically, I need to talk to them, I need to move them, I need to assess them, I need to palpate their spine, I need to palpate the muscles, I need to move the joints, I need to check the reflexes, I need to talk to them to get to know their body type, their attitudes and belief system, and so many questions that I need to ask. I have to perform certain movements and check whether certain movements are worsening them or improving them. I need to give them the exercise and check whether the exercises are worsening them or improving them. Then we create a protocol and advise them to continue at home with our guidance. So what works for one patient will not work for the other patient. Apart from diagnosis, you need to place the patient considering all these factors and where he falls under. Then the treatment protocol can be started based on those factors. Adding to the disc pathology, some people will have associated findings, like some people would have modic changes. Modic changes are nothing but, when the disc is compressed, it will go and disturb the vertebral bodies. When the disc is compressed so much, some amount of disc material will go and impact the undersurface of the vertebral body. Thereby, the vertebral body itself will undergo certain changes, which can be seen as hyper-intense or hypo-intense signals in T1 and T2 weighted MRI image. So that we call it as a modic changes. When there is a modic change, we understand that the problem is very old, because it takes many years for the modic changes to happen. Most of the time it can be painless, but sometimes it can cause vertebrogenic pain, more of a non-mechanical central pain. In such vertebrogenic pain, no amount of exercise can cure the pain. It needs certain other forms of treatment. Some people would have small nodules. The disc material will infiltrate into the body and it creates a dent in the vertebral body, and that dent can be very easily seen in the MRI. We call that as small nodules. Both modic changes and small nodules are mostly secondary to the primary disc pathology. Only if the disc is degenerated, then it can go and affect the vertebral body. So again, it's all narrowing down to the disc pathology. Some patients would have high intensity zone as seen in the MRI. We call that as HIZ. Some patients would have ligamentum flame hypertrophy along with the disc herniation. So when someone has both disc herniation and ligamentum flame hypertrophy, that causes more central canal stenosis than the disc herniation alone. The next one is facet joint hypertrophy. 70 to 80% of the load of the spine is transmitted from the bone to the disc to the next underlying bone. Remaining 30% of the weight goes to the facet joint. Now, when the disc is desiccated, the disc cannot transfer the weight, so majority of the weight will go to the facet joint. That way the facet joint will get affected. So here the facet joint hypertrophy or facet joint arthritis is also primarily due to the disc pathology, unless until if the patient is very young and athletic, wherein their pathology is little different, they can have a primary facet joint problem. But for the majority of the middle-aged people who are getting facet joint hypertrophy would be having their hypertrophy secondary to the disc degeneration. Apart from that, some patients would have osteophytes in the bones. Some osteophytes can be positioned in a very tricky way, and that causes non-mechanical pain. Though majority osteophytes are harmless, some are. Rarely, some people would have discitis, something like osteomyelitic changes happening in the disc vertebral complex, infection happening in the disc. That would be the reason for the pain. It can be confirmed by MRI as well as the blood test, and then these people need antibiotic treatment. Lastly, there is something called disc osteophyte complex, which we commonly see in the cervical spine, not in the lumbar spine. So once the disc material becomes calcified, we call it as disc osteophyte complex. That can become like a hard disc, which will be so resistant for exercises. When the disc is becoming like a hard bone, then it's hardly amenable to change. So that poses serious challenge for us. So apart from the primary discogenic pathology, some patients would have associated finding that can contribute to pain, or they can be coincidental. And in the MRI, you see so many other findings. Sometimes hemangiomas will be there, sometimes sacralization, lumbarization would be there. Most of the times they are merely coincidental. Sometimes they can be the reason for the pain. So with all the discussion we did about the back pain, by now you understood how complex it is to diagnose and treat the patients with low back pain. Diagnosis from our perspective is more or less easy. We know what causes the pain, but the treatment is what is even more challenging. Some patients need exercises, some patients need just rest, some patients need a lot of movement because these are people who are static sitting people. Some patients need sometimes medications, some patients genuinely need surgery. Even though it is only 5% of all the discogenic back pain sufferers, still that 5% of the people should be referred correctly so that they get the right intervention. And every physiotherapist who is treating patients with back pain do understand this complexity, and accordingly you try to manage your patients. And patients who are watching this video, do understand why you are not improving, because you may be falling under one of these categories, so that your part, what you are suffering, is not addressed yet. That's why you are still suffering with the pain. There is no magic exercise for back pain. Mobility exercise, flexibility exercise, yoga, strengthening, core, they all looks good, excellent face value, but we all know that it doesn't work for everybody. Maybe for some random patients it will work beautifully, but I'm talking here about the average people. I'm not talking about those random 1 or 2 people who got miraculous improvement with some miraculous therapy. I'm talking about the average general population who are still suffering with this pain, who are not yet getting the answers. All I ask is, get the diagnosis done, get to know what is the contributing factors for your pain, and please get the timely intervention. The longer you wait, the more it is going to be difficult for your treating doctor as well as for you. Let's make the world less of back pain sufferers.